Imagine a nurse, right? They are walking down a super quiet hospital corridor.
Like the middle of the graveyard shift.
Exactly. It is maybe 2 in the morning, and they glance into a room just passing by.
Okay.
And they catch a colleague slipping a patient's prescribed pain medication into their own pocket.
Oh, wow. Yeah, that is a total nightmare scenario.
It really is, because in that fraction of a second, before a single word is even spoken, that witnessing nurse is suddenly trapped.
Completely trapped.
They are caught in this terrifying, invisible web. I mean, they are wedged right between criminal law, civil liability, their institutional policy, and of course, a really profound moral duty to the patient actually lying in that bed.
Yeah, it is the ultimate collision of worlds, honestly.
Right.
Because we often think of healthcare purely as this, tangible science, like the broken bone on the X-ray or administering a very precise chemical compound.
Or literally stitching up a wound.
Exactly. But
Yeah.
the reality is that the biology part is really only half the picture.
Just half.
Yeah. The very moment a healthcare professional steps into a clinical space, they are operating within this monumental framework of accountability. I mean, every single touch, every conversation, and even every silence is governed by rules that most people just never see until something goes catastrophically wrong.
Which is exactly why we are here today. So welcome to the Nursing Launchpad program on the LPN Launchpad channel. I am so glad you could join us. Today, we are mapping out that unseen rule book.
It is a big rule book.
It is massive. We are venturing into the complex, sometimes terrifying, but just absolutely fascinating world of the legal and ethical aspects of nursing.
And this matters for everyone listening, right?
Yes, absolutely. Because whether you are someone out there delivering care on the front lines or you are someone receiving that care, understanding these boundaries reveals how the healthcare system tries to protect our dignity and our safety, especially when we are at our most vulnerable.
Yeah, and I think what makes this whole exploration so compelling is the constant friction between the two main forces that govern behavior in this space.
The law and ethics, right?
Precisely. You have the law, which is, incredibly rigid and structured,
Yeah.
and then you have ethics, which are deeply human and often very subjective.
They can be messy.
Very messy. So the legal framework basically establishes the absolute minimum standard of behavior that is required to just keep society functioning without falling into total chaos.
Okay.
You can think of it as the floor.
I love that visual, actually. So the law is the floor that keeps you from falling into the basement of criminal liability.
Exactly.
While ethics would serve as the ceiling, like the highest moral duty you can possibly strive to reach.
That is a perfect way to put it.
Well, to really understand how a provider operates between that floor and that ceiling, I think we need to look at the foundation itself.
Let us do it.
So let us examine the two massive pillars of the legal system that healthcare workers navigate every single shift. That would be criminal law and civil law.
Right, the big two.
Let us start with the first pillar. So, criminal law is essentially about offenses against society as a whole, correct?
Precisely. Yeah. Yeah, criminal law addresses conduct that is considered fundamentally offensive or, detrimental to the public at large.
So it is bigger than just two people fighting.
Much bigger. The entire purpose of the criminal justice system is to punish the offender for the crime they committed, and of course to deter others from committing similar acts.
Okay, that makes sense.
When a crime is prosecuted, it is not just one person suing another person. It is actually the state or the federal government bringing formal charges against the individual.
Because their action kind of threatened the fabric of a civilized society.
Exactly that. And the verdict in these types of cases is totally binary. You are either innocent or guilty.
So taking that into a healthcare setting, this would involve the most severe violations, I imagine?
Oh, absolutely.
Going back to our opening scenario of the nurse stealing the medication?
Right, the drug diversion.
Yeah, that is straight up theft, and it is drug diversion. So society has deemed that specific behavior unacceptable, totally regardless of who the victim is.
Furthermore, the penalties really reflect that societal outrage. We are talking about substantial fines, actual imprisonment, and the permanent revocation of a nursing license.
Because they broke the public trust.
Right. The state literally steps in to remove that individual from the profession entirely because they have proven that they just cannot be trusted with the privileges granted by their license.
Okay, that feels pretty straightforward. You break the rules of civilization, you face the wrath of society.
Basically, yeah.
But civil law operates on a completely different frequency, does it not?
It is a totally different animal.
Because civil law deals with conduct that violates an individual's rights. It is not about society at large anymore.
Right. It is about a specific person who has been wronged. The mechanism of civil law is entirely different because the goal here is not punishment in the traditional sense.
So no jail time.
No, certainly no imprisonment. The primary objective of a civil lawsuit is accountability, and more specifically, restoration.
Restoration.
Yeah, the legal term they often use is making the aggrieved person whole again.
Making them whole again.
Right. It is a formal attempt to restore the individual to the exact position they were in before the harm ever occurred.
You know, that phrase, making the person whole again, it always strikes me as slightly paradoxical when we are talking about a medical context.
Oh, I completely agree.
Because, I mean, if a surgical error results in a patient losing a limb, or a medication error causes permanent neurological damage, the legal system obviously cannot magically restore that limb.
No, it cannot repair brain tissue.
Right. So how do they handle that?
Well, this is why the system relies on the only tool it really has available for restoration, which is financial compensation.
For money.
Money. Because you simply cannot reverse physical harm. So the court calculates monetary settlements that are designed to offset the burden of that harm.
Okay, so what does that actually cover?
It includes covering past and future medical bills, lost wages from being unable to work, and then putting a literal monetary value on pain and suffering.
Which seems impossible to quantify.
It is. It is a highly imperfect system,
Yeah.
but it is the only mechanism we really have to enforce individual accountability.
I am thinking back to our nurse stealing the medication in the middle of the night. It seems like a single action could actually trigger an avalanche in both of these legal arenas at the exact same time.
Oh, it absolutely does.
Because, okay, the nurse steals the drug. They are arrested for theft and drug diversion, which is the criminal law side. Society is punishing them.
Right.
But at the exact same time, the patient in that bed was deprived of their prescribed pain relief, so they suffered unnecessary agony because of that theft.
And that suffering right there opens the door for a civil lawsuit.
Wow.
Yeah, the patient can sue the nurse, and very likely the employing institution as well, for failing to provide the standard of care and causing them direct harm.
So they are fighting a war on two fronts.
Exactly. The nurse is facing the prosecutor in criminal court and the patient's attorney in civil court for the exact same action. They operate under this constant dual threat of liability.
That raises a really critical question, though, about where these laws actually originate.
Okay.
Like when a nurse is standing in a courtroom, what rule book is the judge actually looking at to make these decisions?
Well, the rule book is drafted from multiple levels of government, which creates what we call statutory law.
Statutory law.
Right. Federal, state, and local legislative bodies enact these written laws. For example, the specific rules governing controlled substances, that is, federal statutory law.
Okay.
But written laws cannot possibly account for every single nuanced scenario that happens in real human life, right?
Yep.
Medicine is too complicated.
Right. You cannot write a rule for every weird thing that happens on a Tuesday.
Exactly. And this is where common law enters the picture. Common law is developed organically by the courts over a long period of time.
I have always visualized statutory law as like the official printed rule book for a sport,
Oh, I like that.
while common law represents how the referees have historically interpreted those rules during actual messy games.
That captures the essence perfectly. Common law relies heavily on precedent.
Precedent, okay.
Yeah. When a judge makes a ruling on a really complex medical liability case today, they are not just looking at a textbook. They are looking back at similar cases from 10, 20, or even 50 years ago to see exactly how the law was applied back then.
So the law is not static.
Not at all. This means the legal landscape is constantly evolving based on new precedents being set in courtrooms literally every single day.
Okay, so knowing that this dual system of criminal and civil law exists is foundational, but it still feels, I do not know, a bit abstract.
It can be, yeah.
How does this massive legal apparatus actually filter down to tell a nurse what they are legally allowed to do with a syringe on a typical morning shift?
That filtering happens at the state level through something called Nurse Practice Acts.
Nurse Practice Acts. Okay, let us dig into that.
These are arguably the most important pieces of legislation a practicing nurse will ever interact with in their entire career.
Really, the most important.
Without a doubt. These are specific state laws that formally define and limit the exact scope of nursing practice.
But it changes depending on where you are.
Entirely. Every single state, province, and territory has adopted their own specific version of a Nurse Practice Act.
Oh.
Yeah, they dictate the minimal educational preparation required, the professional standards necessary just to get your license, and the specific functions a nurse is legally permitted to perform to protect public safety.
The geographical aspect of this is just fascinating to me because you could have two hospitals sitting, what, maybe 10 miles apart?
Sure.
But if there is a state border running right between them, the nurses inside those buildings are operating under totally different legal boundaries.
They absolutely are. And the burden of knowing those boundaries falls entirely on the individual professional.
It is not the hospital's job to tell them.
Nope. It is the license holder's explicit legal responsibility to know the specific Nurse Practice Act that is in effect for their geographic region.
That is a lot of pressure.
It is. If a nurse relocates, or even if they just work as a travel nurse across state lines for a few months, they absolutely cannot rely on the rules from their home state.
They have to learn a whole new rule book.
Yes. In the eyes of the law, ignorance of the specific regional requirements never, ever absolves liability. I did not know is not a legal defense.
Okay, so the state law acts as the absolute outer boundary of professional practice.
Right.
I picture it kind of like a fence.
Okay, a fence.
But within that fence, we have standards of care. So how do those differ from the Nurse Practice Act?
So if the Nurse Practice Act is the outer fence, the standards of care are the specific pathways you're allowed to walk on within it.
I see.
Standards of care are very detailed guidelines that define acts whose performance is required, permitted, or strictly prohibited.
And who makes those?
While they derive their ultimate authority from state and federal laws, they are heavily, heavily shaped by professional bodies.
Like?
Organizations like the American Nurses Association. They regularly evaluate the evolving landscape of healthcare, they review new evidence-based practices, and they revise the standards accordingly.
So they keep things up to date with modern medicine.
Exactly. They define the specific obligations of the nurse in actual practical clinical scenarios.
Okay. And then, on top of the state laws and the professional standards, you have the most localized layer of rules, right?
Right.
The institutional policies. Because the specific hospital or clinic has its own massive manual of procedures.
Oh, yes. Employing institutions absolutely have the right to establish highly specific guidelines for nursing activities within their own walls.
So they can get really specific.
Very specific.
Yeah.
They can dictate exactly how a procedure should be documented, which specific brand of equipment to use, and the exact chain of command for reporting any issues.
Okay, but how does that interact with the state laws?
Well, there's a fundamental legal hierarchy here that can never, ever be violated.
A hierarchy.
Yes. An institutional policy must remain strictly within the confines of the state's Nurse Practice Act.
Let me present a scenario because I feel like this happens all the time and causes massive anxiety.
Go for it.
Okay. A hospital is incredibly short-staffed.
Very common.
Right. And they write a new internal policy that allows a certain level of nursing staff to perform a highly specialized procedure just to save time.
Okay.
They even provide a mandatory afternoon training session for it. Everybody goes, everybody learns it.
Right.
But that specific procedure is technically outside the scope of practice defined by that specific state's Nurse Practice Act.
Oh, boy.
Right. So if a nurse follows the hospital's policy, performs the procedure, and something goes horribly wrong, who takes the fall? Because the hospital wrote the rule and provided the training.
I know it sounds counterintuitive, but the nurse takes the fall.
Wait, really? The nurse?
Every single
Yeah.
time. The law is incredibly rigid regarding this hierarchy of authority. The state law always, without exception, overrides an employer's policy.
Wow. Even if you were just doing what your boss told you to do.
Yes. An institution possesses the authority to narrow the scope of practice, meaning a hospital can forbid you from performing a skill that the state legally allows you to do.
Okay.
But they possess absolutely no authority to widen it. They cannot give you permission to do something the state says you cannot do.
So they can build an inner fence, but they can never knock down the state's outer fence.
That is exactly it. A professional cannot hide behind their employer.
That is scary.
It is. But nurses have professional autonomy, which inherently brings individual accountability. Saying, well, the hospital told them to do it, or it was printed right there in the employee handbook, that is simply not a valid legal defense.
The judge will not care.
Not at all. If an action falls outside the state's Nurse Practice Act, performing it is a direct violation of the law, period, which opens the nurse up to massive civil liability and the potential sanction or total loss of their license.
That level of individual vulnerability is intense.
It really is.
It means you have to constantly question authority if that authority asks you to cross a legal line. But how does a court actually evaluate these situations after the fact?
What do you mean?
Well, when a jury of people who do not work in hospitals is trying to determine if a highly trained professional made a mistake, what metric are they even using?
Ah, okay. The legal system relies on what is known as the standard of the reasonably prudent nurse.
The reasonably prudent nurse.
Yes.
Yeah.
When an action is called into question, the court subjects it to a very specific legal test. They compare the nurse's action against what a hypothetical, reasonably prudent nurse of similar education and similar experience would have done under those exact same circumstances.
Prudent meaning careful, wise, and exercising good judgment.
Right.
But how does a jury know what a hypothetical prudent nurse would do? As I said, they do not have medical training.
That is where they rely heavily on expert witnesses.
Ah,
In a malpractice trial, the attorneys will bring in other experienced nurses who actively work in the field. These experts review the medical records and then testify to the jury about exactly what the standard of care was.
no, it is peers judging peers, essentially.
Yes, and it is important to note the court does not demand absolute perfection.
Well, that is a relief.
Right, because they understand that medicine is chaotic. It is unpredictable. But they do demand that the professional adhered to the standard of care that any other careful, wise professional with the same background would have provided in that highly specific situation.
Okay, but what happens when the situation is entirely novel?
Give me an example.
Say a nurse is floated from their regular orthopedics unit over to an oncology unit because of a severe staffing shortage.
Okay, a float situation.
Right. And they are suddenly handed a complex chemotherapy medication they have never, ever seen before. They have the general nursing education, obviously, but they lack the specific experience for this exact task. What happens then?
This is where the legal duty to seek instruction becomes absolutely paramount.
The duty to seek instruction.
Yes. Nursing orientation and general education cannot possibly cover every single skill or new piece of technology that will emerge over a 40-year career.
It is possible.
Right. So when a professional is faced with an unfamiliar practice or procedure, it is their explicit legal duty to seek out additional instruction and direct supervision before proceeding.
They have to stop and ask for help.
They must.
Yeah.
You cannot simply attempt it, hope for the best, and then later claim to the jury that you were just doing your best in a really tough situation. Proceeding without the necessary competence is a direct, undeniable breach of this standard of care.
Which brings us to the inevitable consequence of breaching those standards when things go catastrophically wrong.
The fallout.
The fallout. I want to spend some significant time dissecting two terms that are thrown around constantly in hospital break rooms and definitely on television dramas, usually entirely incorrectly.
I bet I know which two.
Negligence and malpractice.
Yes. Clarifying the distinction between those two concepts is vital because they carry vastly different implications in the real world.
Right, because in casual conversation, people just treat them as synonyms.
They do, but legally, they represent two very different tiers of failure. Let us break down negligence first.
Okay, what is negligence?
Negligence is fundamentally the absence of due care. It is the failure to act in a manner demonstrating the care and knowledge that any prudent individual would exercise. At its core, negligence is just carelessness.
But the key here is that it does not require specialized medical knowledge, right? Like anyone can be negligent.
Exactly. That is the defining feature. Professional-level judgment is not a required element to establish a charge of negligence.
Okay.
For example, if you are walking through a grocery store and you see a massive puddle of water in the aisle and you fail to put up a wet floor warning sign and someone slips and shatters their hip, you could be found negligent.
Because any normal person knows water is slippery.
Right. So in a healthcare environment, literally anyone on a staff can be charged with negligence, including unlicensed assistive personnel.
Okay, so what would that look like in an actual patient's room?
It involves actions that any reasonable person, totally regardless of their medical training, would know are inherently unsafe.
Like what?
Like leaving a bed rail down on a severely disoriented patient's bed when the care plan explicitly requires to be up, which then results in a fall.
Okay.
Or failing to clean up a spilled bodily fluid on the floor that leads to someone slipping. Or using a piece of equipment that has a visibly frayed, sparking electrical cord and causing a shock.
So it is a general action that is just careless and fails to provide a baseline expected level of safety.
Exactly. General carelessness.
So if negligence is general carelessness, malpractice must be a very specific, elevated category.
It is. Malpractice is the formal term for professional negligence.
Professional negligence.
Right. It applies exclusively to professionals who are held to those higher standards of care we discussed a few minutes ago, such as physicians, advanced practice providers, and nurses. It involves a severe breach of a specialized duty that directly results in patient harm.
Now, the bar for proving malpractice in a courtroom is notoriously high, is it not?
Extremely high.
I was reading about how attorneys actually construct these cases, and there is a very rigid four-part formula.
Yes, the 4 elements.
And all 4 elements must be definitively proven to establish liability. If even one is missing, the entire malpractice case just collapses.
It falls apart completely.
Let us walk through the anatomy of a lawsuit by examining these 4 elements in detail. What is the very first hurdle an attorney has to clear?
The first element is duty. The plaintiff must prove that an established relationship actually existed between the patient and the healthcare provider.
Okay.
The provider must have actually owed a legal duty of care to that highly specific individual at the exact time of the incident.
That seems pretty obvious on the surface, honestly. I mean, if you are assigned to a patient for a 12-hour shift in the hospital, you obviously have a duty to them.
Right.
But where does the line actually end? For instance, if a nurse is off the clock, wearing street clothes, and walking to their car in the hospital parking garage, do they still owe a legal duty to a random stranger who suddenly collapses in front of them?
That is an excellent question, and it really delves into the nuances of Good Samaritan laws, which vary wildly by state.
Oh, really?
Yeah. Generally speaking, unless the nurse explicitly steps in and actively initiates medical care, which thereby creates that relationship, they may not have a strict legal duty to act in a civilian capacity while they are completely off the clock.
Interesting.
But the very moment they are on the clock and they accept a patient assignment, that duty becomes ironclad.
Okay, so assuming duty is firmly established, we move to the second element, which is breach of duty.
Correct.
Yeah.
This requires proving that the professional failed to perform that established duty in a reasonable, prudent manner.
So this goes back to the standard of care.
Exactly. The plaintiff's legal team must demonstrate exactly what the standard of care was for that specific scenario, and then definitively show the jury that the nurse's actions, or their failure to act, fell well below that standard.
And this is where the battle of the expert witnesses usually takes place, right?
This is exactly where that happens.
Yeah.
Experts arguing over what a prudent nurse would have done.
Which leads us to the third element, which is harm. And this one fascinates me because it really reveals a cold, somewhat calculated aspect of civil law.
Oh, say?
Well, the patient must have actually suffered some demonstrable harm, right?
Yes, it is the absolute hinge upon which the entire concept of compensation rests.
Because if we recall that the whole purpose of civil law is to make the aggrieved person whole by compensating them for damages, there obviously must be actual damages to compensate.
You cannot compensate a zero balance. Now, I should clarify, harm does not always have to be a gruesome physical injury.
What else can it be?
It can be severe emotional distress, it can be a prolonged hospitalization, or massive financial devastation resulting from an error. But tangible, provable harm must have occurred.
Okay, let me throw a wrench into this formula just to see how it holds up in a weird scenario.
I'm ready.
Let us say a nurse is working in an intensive care unit. They are utterly exhausted.
It happens.
They pull the wrong intravenous medication and they administer it to a patient. This is an egregious error.
Huge error.
They had a duty, and they clearly breached that duty by failing to follow basic medication administration protocols.
Yes, clearly a breach.
However, by some miraculous twist of human biology, the wrong medication actually stabilizes the patient's underlying condition.
Oh, wow.
The patient suffers absolutely zero negative consequences and is discharged the very next day feeling totally great.
A miracle patient.
A miracle patient. Is that malpractice?
Based on this strict legal definition we just walked through, no, it is not malpractice. Really, you have duty and you have a severe breach of duty. But that third element, harm, is entirely absent.
So no harm, no foul in civil court.
Exactly. Without harm, the civil court literally has nothing to compensate the patient for. The lawsuit would fail immediately.
But wait, the nurse cannot just walk away whistling? I mean, they made a potentially fatal error. They could have killed someone.
Oh, they will definitely not walk away unscathed. But the consequences simply shift from the civil courtroom over to the regulatory and institutional arenas.
Ah, okay.
So the patient cannot successfully sue for malpractice, but the employing hospital will absolutely, very likely, terminate the nurse for a gross violation of safety policies.
Which makes sense.
Furthermore, the state nursing board can launch a full investigation and potentially suspend or completely revoke the nurse's license for unsafe practice, even though no actual harm occurred to that specific patient.
Because they proved they're dangerous.
Right. Professional accountability exists completely independently of civil liability.
Okay, that makes a lot of sense. That brings us to the fourth and final element, which I have heard is notoriously difficult for attorneys to actually prove: proximate cause.
Proximate cause is often the most brutal part of a trial.
Why is that?
It requires demonstrating that the breach of duty was the direct, undeniable, straight-line cause of the harm. The occurrence of the harm must have depended directly on the occurrence of the breach.
I always think of this like a domino effect versus, I do not know, a coincidental breeze.
Explain that.
Like, if you push the first domino and it knocks over the entire line, you are the proximate cause.
Right.
But if you push the first domino and simultaneously a massive gust of wind blows through the window and knocks the rest over, your push wasn't the sole cause of the collapse.
That is a great analogy.
In a chaotic medical environment, separating the domino effect from the wind seems nearly impossible.
It is incredibly complex. Consider this scenario. A patient is admitted with severe end-stage advanced heart failure. A nurse negligently forgets to administer a routine dose of an antibiotic for a very minor skin infection.
A breach of duty.
Yes. 2 hours later, that patient suffers a massive, fatal cardiac arrest caused entirely by their underlying heart failure.
Oh, man.
The family eventually gets the records, discovers the missed antibiotic, and tries to sue the nurse for malpractice.
Okay, let us run the formula. The nurse had a duty, obviously. They breached it by missing the medication. And the ultimate harm, death, absolutely occurred.
But the case fails on proximate cause.
Because of the wind.
Because of the wind. The plaintiff cannot possibly prove that missing one single dose of a minor skin antibiotic directly caused a fatal cardiac arrest in a patient who already had terminal heart failure.
Right.
The breach and the harm happened in the exact same time frame, yes, but one did not cause the other. A did not cause B. Establishing that direct, unbreakable chain of causality is often the most grueling part of malpractice litigation.
Wow. While understanding these rigid legal formulas is obviously vital, I was actually reading through some fascinating research on the anatomy of real-world lawsuits. And it turns out the biggest predictor of whether a provider gets sued often has absolutely nothing to do with proximate cause or statutory law.
Let me guess. It has to do with human psychology.
Yes, it is entirely about human psychology.
You are referring to the impact of the nurse-patient relationship.
I am.
Extensive studies into medical litigation reveal time and time again that a poor relationship is actually a leading factor in whether a patient or their family decides to seek legal action after an adverse event.
It is astonishing to me. Because you could have two different nurses make the exact same medication error resulting in the exact same harm.
Same formula, same outcome.
Exactly. And the patient might sue one nurse for millions and completely forgive the other nurse based entirely on how they were treated during the shift.
It is entirely true. When patients feel genuinely respected, when providers take the time to actually sit and listen to their concerns, and when communication is transparent and empathetic, patients are significantly less likely to file a lawsuit, even when a measurable, harmful error occurs.
Why is that?
Because they view the provider as a fallible human being who tried their best and made an honest mistake.
They see the humanity.
Right. Conversely, if a provider is arrogant or dismissive or actively avoids communicating with the family, the patient views the error not as a mistake, but as a personal insult.
An insult. Wow.
Yeah. Good communication and positive relationships are, in a very practical and legally proven way, highly effective legal defenses.
That just brings the humanity right back into the center of this cold legal framework. It proves that you cannot divorce the science of care from the art of human connection.
You really cannot.
But, while avoiding malpractice requires doing things correctly in the light of day, there is another massive area of liability that revolves entirely around what happens in the shadows. I am talking about the formidable shield of privacy and confidentiality.
The landscape of privacy changed permanently with the enactment of the Health Insurance Portability and Accountability Act of 1996.
That was a huge turning point.
A monumental shift. Because before this specific legislation, patient information flowed relatively freely, often to the profound detriment of the individual.
Right.
This act completely, utterly revolutionized how the entire healthcare industry manages data. It established strict, absolutely uncompromising rules on exactly who has permission to access, view, and transmit health information.
We all sign those exhaustive privacy forms on clipboards every single time we visit a new clinic.
We do.
But I think the general public fundamentally misunderstands what actually constitutes protected health information.
They definitely do.
Most people just assume it means their name attached to a sensitive medical diagnosis.
The legal definition is vastly more expansive than just a name and a diagnosis. Protected health information encompasses virtually any data point, any at all, that could conceivably be used to identify a specific individual within a healthcare context.
So what does that include?
Well, it includes obvious identifiers like social security numbers, home addresses, and photographs. But it also includes things you would not think of, like admission dates, discharge dates, vehicle license plate numbers, and even medical device serial numbers.
I was actually reading through the Department of Health and Human Services guidelines on this in preparation for today, and what genuinely shocked me was the specific rule regarding the age of elderly patients.
Ah, yes. You were referring to the mandate that the age of any patient who is 89 years of age or older is legally considered a direct identifier,
Yes.
and therefore it must be protected as highly sensitive information.
Why specifically 89? I mean, it seems like such an arbitrary number to draw a legal line in the sand. Why not 85 or 90?
It is actually based on actuarial tables and the stark realities of demographics.
Okay, explain that.
When you look at the population distribution, especially in smaller towns or really rural zip codes, the sheer rarity of individuals who survive to their late 80s and 90s makes them statistically unique.
Oh, I see.
If a healthcare worker casually mentions to a friend at a coffee shop, "Oh, we had a 94-year-old come into the clinic today," in a town of maybe 3,000 people, the listeners might immediately know exactly who that is.
Because there's probably only one 94-year-old in town.
Exactly. The law is incredibly thorough in identifying and shielding anything that could compromise a person's anonymity.
And all of this highly granular data lives inside the medical record, which I think people often view simply as a benign diary of their health.
It is not a diary.
It is much heavier than that.
Medical records are not public documents. They are strict, binding legal documents. They must be permanent, they must be accurate, complete, and perfectly legible.
Because they go to court.
Right. They are the primary source of truth utilized in courts of law to prove whether standards of care were actually met, whether a breach of duty occurred, and whether informed consent was properly documented.
You know, when we think about massive privacy breaches, our minds automatically jump to a cinematic scenario.
Like a hacker.
Yeah, a malicious hacker in a dark basement infiltrating the hospital's mainframe to steal thousands of credit cards and health records. But in reality, the most dangerous breaches are usually entirely mundane and totally accidental, right?
Absolutely. The colossal fines and career-ending disciplinary actions usually stem from everyday human carelessness, not cyber warfare.
Give me an example.
We are talking about two professionals discussing a highly complex case while riding in a crowded hospital elevator, just assuming the people around them are not listening or do not care.
Which they always are.
Always. Or we're talking about a nurse printing a shift report sheet, putting it in their scrub pocket, and then accidentally tossing it into a regular cafeteria trash can instead of a secure shredding bin.
I actually like to compare patient data to highly radioactive material.
Oh, that is a good one.
Right. Because it is not just the massive explosive leaks that are dangerous. Even a microscopic, totally invisible leak, like a casual conversation in a hallway, or leaving a computer monitor logged in and angled toward a visitor's chair that can permeate the environment and cause massive legal fallout years down the line.
Taking that radioactive analogy even further, just as radiation damages physical tissue, these privacy breaches severely damage the fundamental tissue of trust that holds the entire healthcare system together.
Wow.
The legal concept of invasion of privacy involves a person's absolute undeniable right to be left alone and remain anonymous if they choose to.
Right.
And it is crucial to understand that simply walking through the front doors of a hospital and consenting to medical treatment does not waive your right to privacy.
So the physical space matters just as much as the digital data on the screen.
Oh, absolutely.
Like failing to pull a privacy curtain closed during a physical examination or leaving a door ajar while a patient is exposed. That is a literal invasion of privacy.
It is a profound violation. If we step back and really look at why the government enforces the Health Insurance Portability and Accountability Act so aggressively, it is fundamentally about preserving the efficacy of medicine itself.
How so?
If a patient feels that their deepest psychological struggles or their physical vulnerabilities or their highly stigmatized infectious diseases will somehow become public knowledge, they will deploy defense mechanisms.
Got things.
Exactly. They will stop disclosing vital information. They will
Oh.
lie about their symptoms. They will lie about their substance use, or they will hide their sexual history.
And if the provider is operating on false or incomplete information, the quality of care just completely disintegrates.
The whole system fails.
The entire system collapses without that ironclad vault of trust.
Right.
However, the law is full of contradictions.
It is.
Because the provider is legally mandated to be this impenetrable vault of secrecy, except for the specific moments when the law explicitly demands that they shatter that confidentiality and sound a loud alarm,
Yes.
which introduces the massive complexities of consent, competence, and the duty to report. Let us tackle the concept of consent first.
Consent is the gateway to all medical intervention.
Okay.
Every single patient has the fundamental right to completely understand exactly what is going to happen to their body. This relies on the legal doctrine of informed consent.
What does that require exactly?
It requires full disclosure of the anticipated risks, the expected benefits, any alternative treatments that might be available, and the potential consequences of refusing treatment entirely.
So you cannot just say, sign this, you will be fine.
No, not at all. The consent must be given voluntarily, completely free of any coercion or manipulation from family or staff, and it must be properly documented in that legal medical record.
Now, there is a lot of confusion regarding who actually bears the legal responsibility for securing that informed consent.
Yes, this is a common misconception.
Because if a patient is prepped for surgery, you often see the nurse walking in carrying the clipboard with the consent forms.
Right.
So does the legal burden fall on the nurse?
No, it does not. And this is a critical legal boundary to clearly define. The specific physician, surgeon, or advanced practitioner who is actually performing the procedure is legally responsible for obtaining the informed consent.
Because it is their procedure.
Exactly. It is their procedure and their liability. The nurse's role is distinctly different.
What is their role then?
The nurse may bring the form into the room, and they may sign it as a witness to confirm that the patient signed it voluntarily. But they are not the ones explaining the intricate surgical risks.
But the nurse is right there in the room. What happens if the physician does a terrible rushed job explaining a highly complex procedure, the physician leaves, and the patient looks at the nurse and says, I have absolutely no idea what he just said, but I guess I will sign this paper.
That is exactly where the nurse's role as a fierce patient advocate activates. If the nurse assesses that the patient does not truly understand the intervention, or if the patient is under the influence of heavy narcotics that impair their judgment, the nurse has a strict legal and ethical obligation to halt the entire process.
Just stop the train.
Pull the emergency brake. They must refuse to witness the signature. They must notify the physician that informed consent has absolutely not been achieved, and they must advocate for the patient until true understanding is reached.
And all of this relies entirely on the patient's capacity to understand the information in the first place, which introduces the concept of competence.
Right. In the eyes of the law, a strong presumption exists that any person who has reached the age of majority, typically 18, is legally competent to make their own decisions.
But competence in a medical setting is dynamic, is it not?
It is highly dynamic.
Hmm.
A patient must possess the cognitive capacity to understand the specific information presented and the grave consequences of their choice.
What if they do not?
If a patient is legally incompetent due to, say, profound dementia, a severe traumatic brain injury, or simply being a minor child, they cannot provide informed consent.
So in those scenarios, a designated legal representative, such as a parent or a court-appointed guardian, must step in to receive the information and consent on their behalf.
Exactly.
Okay, so that covers the interventions we actively want to perform. But let us look at the dark side of this tension.
Okay.
What happens when the healthcare provider discovers something deeply troubling that the patient desperately wants to keep secret? When does the vault of the Health Insurance Portability and Accountability Act get legally forced open?
This introduces the legal concept of mandated reporting.
Mandated reporting.
Yes. While confidentiality is paramount, healthcare professionals are required by state and federal law to report certain specific, highly sensitive information to the appropriate legal or public health authorities, completely regardless of the patient's desire for privacy.
Wow. What falls under this mandate?
The most prevalent examples involve the protection of vulnerable populations. So, suspected child abuse, suspected elder abuse, and intimate partner violence often trigger mandatory reporting protocols to law enforcement or child protective services.
What about diseases?
Yes. Additionally, certain communicable diseases that pose a severe threat to public health, such as active tuberculosis or certain newly emerging, highly contagious pathogens, those must be reported to the health department so they can track and contain outbreaks.
I honestly cannot imagine the psychological burden this places on a provider.
It is immense.
Because, think about it. They are sitting in an exam room, desperately trying to build trust with a terrified, vulnerable patient just so they can provide basic care.
Right.
But at the exact same time, their legal brain is evaluating the odd bruising on the patient's arm, realizing they are literally mandated by law to call the authorities the moment they step out of the room. An action that will likely destroy whatever fragile trust they just managed to build.
It is an agonizing professional tension. The law is essentially forcing a brutal compromise between two vital conflicting interests.
Which are?
On one hand, you have the individual's absolute right to privacy and self-determination, and on the other hand, you have the broader safety of society and the protection of those who are fundamentally unable to protect themselves.
That is so hard.
It is. You must maintain trust to heal. But the rigid legal framework dictates that you cannot allow silent systemic harm to continue when your intervention could prevent a tragedy. Navigating that space requires impeccable clinical and moral judgment.
This tension surrounding who gets to make decisions and when intervention is actually required becomes infinitely more complex when we look at the end of a patient's life.
It certainly does.
Because what happens when a patient knows they're going to lose their competence in the near future, when they want to ensure their voice still echoes in the hospital room even when they can no longer physically speak?
This desire sparked a massive legislative shift.
Yes, the Patient Self-Determination Act.
Passed in 1991. It was a monumental piece of legislation that fundamentally altered the power dynamics of terminal care.
What did it actually do?
It requires that all healthcare institutions that receive federal funding maintain written policies regarding a patient's fundamental right to accept or refuse medical treatment.
Okay.
But more importantly, it legally mandates that institutions proactively inform patients of their right to formulate advanced directives.
Advanced directives. We hear that umbrella term constantly in discussions about end-of-life planning. Let us break down what these documents actually do.
Advanced directives are highly formalized, signed, and legally witnessed documents. They provide specific instructions for healthcare treatment that are to be followed if a person becomes legally incompetent or lacks the clinical capacity to make those decisions personally at the exact moment they are needed.
So they're kind of like a time capsule.
Exactly. Crucially, these documents sit totally dormant. They only become legally active when the patient loses their voice.
There are two main pillars under this umbrella, right? Let us look at the first one. The living will.
A living will is a written document that serves as a direct communication from the patient to the medical team.
What does it say?
It specifies exactly which life-saving treatments or life-prolonging interventions are acceptable to the patient and which are not in the event they are diagnosed with a terminal condition or fall into a persistent vegetative state.
From what I understand, they're incredibly valuable, but they have a distinct limitation.
They do.
Because they are philosophical documents, not strictly clinical ones.
Right.
They express a broad desire like, I do not want to be kept alive by artificial means, but they cannot possibly anticipate every hyper-specific medical crisis that might occur at 3 a.m.
That is their inherent weakness, yes. But they offer a massive legal benefit to the staff.
Oh.
If a healthcare worker acting in good faith follows the directions outlined in a valid living will, even if following those directions results in the patient's death, they are granted sweeping immunity from civil and criminal liability. The law fiercely protects the provider who respects the patient's documented autonomy.
But because a piece of paper cannot answer a doctor's nuanced clinical question, the law provides a second tool to fill the gaps, right?
Yes.
The durable power of attorney for healthcare.
Often referred to as a healthcare proxy. This document is less about what specifically should be done and much more about who gets to decide.
Okay.
It designates a specific surrogate or agent, usually a highly trusted family member or close friend, to make real-time healthcare decisions on the patient's behalf when they are incapacitated.
This sets the stage for one of the most volatile emotional explosions that can happen in an intensive care unit.
Oh, absolutely.
I want to pose a scenario.
Go ahead.
Okay, a patient has a meticulously drafted living will stating they absolutely do not want to be placed on a mechanical ventilator.
Very clear instructions.
Very clear. They also assign their adult daughter as their healthcare proxy. The patient suffers a massive stroke and cannot communicate. The medical team is preparing to follow the living will and provide only comfort care.
Because that is what the paper says.
Exactly. But the daughter, suddenly crushed by the overwhelming grief of losing her mother right in front of her, screams, "No, ignore the paper, do everything you can, put her on the machine, save her."
It is a devastating, totally heartbreaking reality that plays out in hospitals every single day. The emotional weight in that room is suffocating.
I cannot even imagine. What do you do?
Well, from a strict legal standpoint, the rules are exceptionally clear.
Really?
Yes. The proxy is legally obligated to act on the patient's behalf according to the patient's previously expressed wishes, not according to the proxy's personal feelings or their immense grief in the moment.
So the proxy is just a microphone.
Exactly. The proxy is designated to serve as the voice of the patient, not to override the patient.
So the hospital's legal and ethical duty is to follow the living will, even if the family is literally threatening a massive lawsuit in the hallway.
Yes. In complex cases where the proxy demands aggressive treatment that clearly violates the written advance directive, the hospital's ethics committee and legal counsel must often intervene.
To do what?
To protect the patient's autonomy, even if it deeply traumatizes the surviving family members. The patient's wishes are paramount.
To help bridge the gap between those broad legal documents and immediate clinical action, the medical field also utilizes highly specific medical orders, correct?
They do.
Things like do not resuscitate orders.
Exactly. A do not resuscitate order, or DNR, is a specific, highly actionable medical order written directly into the patient's chart by a physician.
When does that happen?
It is usually established after extensive consultation with the patient or their proxy,
Right.
when the patient's condition is actively deteriorating and there's very little medical hope for meaningful recovery.
And what does it legally do?
When that order is signed, it legally prohibits the nursing staff from initiating cardiopulmonary resuscitation if the patient's heart stops.
Now, I have also read about something called physician orders for life-sustaining treatment. How does that differ from a standard do not resuscitate order?
It is a much more comprehensive and modern approach. It is usually a brightly colored medical form completed collaboratively by the provider and the patient.
Okay.
And it translates broad patient preferences into highly specific, actionable medical orders that actually travel with the patient across care settings, from the nursing home to the ambulance to the hospital.
So it does not just cover CPR.
Right. It dictates exact wishes regarding intubation, the use of feeding tubes, and even antibiotic use. It has proven remarkably effective in preventing the medical errors that often arise from misinterpreting a vague living will during a chaotic emergency.
If we step back and view this entirely from a wide-angle lens, we are witnessing a monumental shifting landscape in how society approaches the very end of life.
We really are.
Because for decades, the dying process was aggressively medicalized. It was controlled by massive institutions, it was driven by technology, and it was often stripped of humanity.
It became very clinical and cold.
But these laws, the Patient Self-Determination Act, the proliferation of advanced directives, they are actively shifting the locus of control away from the hospital machinery and placing it squarely back into the hands of the individual.
It fundamentally changes the psychological experience of terminal illness.
How so?
Well, when you grant a patient control over the circumstances, the environment, and the clinical management of their dying process, you allow them to retain their dignity in the face of the inevitable.
That is powerful.
We are even seeing a profound shift in terminology, moving away from the stark clinical do not resuscitate toward phrasing like allow natural death.
Allow natural death. I like that.
Yes, particularly in pediatric and palliative populations. It is a linguistic shift that acknowledges the reality of human mortality while deliberately choosing to forego aggressive, painful, and ultimately futile treatments.
It is profound because it reveals the beating heart beneath all this intense bureaucracy we have been talking about. These legal documents ensure the patient's wishes are followed, but those wishes are ultimately rooted in their deeply held personal values.
Yes, their morals.
And that brings us to the highest, most complex standard of practice. We started at the legal floor today. We have now finally arrived at the ethical ceiling.
The ceiling. Legal rules like the Nurse Practice Acts dictate what you must do to avoid going to prison or bankrupting yourself in a civil suit.
Right, the bare minimum.
But ethical principles impose an infinitely higher duty. Nursing ethics propose the moral duties, the philosophical obligations, and the ultimate ideals that a professional owes to their patients, their colleagues, and society as a whole.
Let us unpack the core ethical principles that serve as the internal compass for every single clinical interaction.
Okay.
We have to start with the bedrock. What is the first and most fundamental principle that all the others are built upon?
The absolute bedrock of medical ethics is the principle of respect for people.
Respect for people. It sounds so simple.
It sounds simple, but its implications are staggering in practice. It dictates that all human life is inherently sacred. Each individual possesses profound, undeniable worth simply because they are a person.
It strips away all the societal labels we usually use to value people, right?
Exactly.
Yeah.
To a healthcare professional operating ethically, no one person is intrinsically more important than another.
Really?
Yes. The CEO of a Fortune 500 company and a person experiencing chronic homelessness who struggles with severe substance use disorder have the exact same worth in a hospital bed.
Wow.
They are identically entitled to respect, dignity, and exhaustive clinical effort, completely, regardless of their background, their financial status, or the life choices that brought them to the hospital in the first place.
It is a radical, almost subversive kind of equality.
It is beautiful.
And from that foundation of absolute respect, we derive the second principle, autonomy.
Autonomy refers to the freedom of personal choice. It is the inherent right to be independent and to make decisions freely regarding one's own body and life. Okay, this is the philosophical engine that powers the legal concepts we discussed earlier, like informed consent and the right to refuse treatment.
I imagine autonomy is incredibly difficult to respect when the patient is making a choice, will absolutely harm them
Oh, it requires immense professional discipline.
because you want to save them.
Right.
Yeah.
Even if a nurse completely disagrees with a patient's decision, even if they know the decision is completely irrational or potentially fatal, they must respect the patient's autonomy to make it, provided the patient is legally competent.
That has to be agonizing.
It is. You can educate, you can plead, you can furiously advocate, but you absolutely cannot coerce.
The next principle seems to be the driving force that brings people into the healthcare profession in the first place. Beneficence.
Beneficence simply means doing good or acting actively for someone's benefit. The professional has an ethical duty to protect life, alleviate suffering, and proactively promote the well-being of all patients.
It is the affirmative action of healing. But beneficence does not operate in a vacuum. It is constantly checked and balanced by its twin principle, non-maleficence.
Yes. Non-maleficence is the ancient commitment to do no harm.
Which is trickier than it sounds.
Because in modern medicine, this is rarely black and white. Almost every single intervention carries a risk of harm. Administering chemotherapy is technically poisoning a patient to save them from cancer.
Right.
So non-maleficence demands that providers constantly, obsessively weigh the potential benefits of treatments against the potential risks. You passionately want to do good, which is beneficence, but you must first ensure you do not cause unnecessary, disproportionate harm in the attempt.
And the final major pillar of this ethical framework is justice.
Justice is the concept of fairness and equity.
Okay.
It demands that all patients have the exact same right to nursing interventions. In a system characterized by finite resources, limited time, limited medications, limited intensive care beds, justice dictates that those resources must be allocated based purely on clinical need, entirely without bias, prejudice, or discrimination.
When you list them out like that, respect, autonomy, beneficence, non-maleficence, justice, they sound pristine and harmonious.
Very neat and tidy.
Right. But when you apply them to the messy reality of human biology, they must constantly violently crash into one another.
Oh, they collide constantly.
This is the realm of ethical dilemmas.
That is the perfect definition of an ethical dilemma.
Yeah.
It occurs when a situation arises where fulfilling one fundamental ethical principle requires violating another. There's just no clean answer.
I was actually reading a case study that perfectly illustrates this terrifying collision.
Sure.
A patient is brought into the emergency department experiencing severe internal bleeding. They desperately need a blood transfusion to survive. But the patient is a devout member of a faith that strictly forbids receiving blood products.
Okay, a classic dilemma.
The patient is fully competent, and they look the doctor in the eye and say, "Do not give me blood. It violates my soul."
It is the classic agonizing clash.
How do you even process that?
On one hand, you have the principle of autonomy. The patient has the absolute right to dictate what happens to their body and to practice their religion freely.
Right.
But on the other hand, The entire medical team is burning with the duty of beneficence and non-maleficence. They know they can save this life in 10 minutes with a simple bag of blood, and letting the patient die feels like a profound failure to do good.
It is a massive intellectual and emotional challenge. You have a room full of brilliant, highly trained professionals basically paralyzing themselves because they have to choose what seems more right and slightly less wrong.
And you absolutely cannot navigate these labyrinthine dilemmas without engaging in deep value clarification.
What does that mean?
A professional must deeply interrogate and understand their own personal biases and moral framework. More importantly, they must actively recognize and respect complex cultural considerations.
How heavily does culture dictate the outcome of these dilemmas?
It changes the entire paradigm. We often assume everyone views the world through a Western, highly individualized lens, but people from different cultural backgrounds define health, illness, suffering, and the very concept of family roles in vastly different ways.
I imagine the definition of autonomy itself even changes.
Yeah, drastically.
Yeah.
In many cultures, the concept of individualized autonomy is actually viewed as isolating and profoundly disrespectful.
Really?
Yes. Healthcare decisions are not made by the individual lying in the bed. They are made collectively by the extended family or by a designated community elder.
Wow. So the rules totally shift.
A nurse must be acutely aware of these profound differences. Imposing your own cultural expectations of how a patient should act onto a patient who operates under a completely different paradigm is not just arrogant, it is a profound ethical failure.
This brings up a final, truly fascinating question about boundaries. We have spent an hour talking about the patient's autonomy, the patient's rights, and the provider's legal duty to the patient. But what about the professional's autonomy? What if a nurse is ordered to participate in a perfectly legal, standard medical procedure, perhaps an elective termination of pregnancy, or the withdrawal of life support that violently clashes with the nurse's own deeply held religious or moral beliefs?
That is a tough one.
Must they sacrifice their own soul just to do their job?
They do not. The principle of autonomy absolutely extends to the professional as well. A nurse possesses the ethical right to refuse to participate in specific treatments or procedures if participating would cause a profound violation of their personal moral or religious beliefs.
Wait, really? But they cannot just walk out of the room and leave a patient bleeding on a table because they suddenly had a moral crisis, right?
Absolutely not. That introduces the massive caveat of patient abandonment.
Ah, abandonment.
While a nurse can legally and ethically refuse to participate, they cannot simply abandon the patient. They must proactively communicate their objection to their supervisors well in advance whenever possible.
So they have to plan ahead.
Yes. And they must ensure that alternative competent care is seamlessly arranged, so the patient's care is not delayed or compromised in any way. Furthermore, while they can refuse a specific procedure, they can never, under any circumstances, refuse to care for a specific patient based on who that patient is.
It is an incredible, almost impossible tightrope to walk every single day.
It takes immense skill.
I mean, you have to fiercely honor the patient's intricate values, protect your own moral integrity, meticulously follow the rigid state laws, adhere to evolving professional standards, and somehow navigate institutional policies, all while delivering hyper-complex, physically demanding medical care in a high-stress environment.
It is exhausting, but it is also exactly what elevates the profession.
So,
It proves that nursing is not merely a technical or scientific discipline, it is a profoundly moral one.
I love that.
The legal requirements, the criminal law, the civil law, the Nurse Practice Acts, the Health Insurance Portability and Accountability Act, they pour the concrete and build the reinforced walls of the hospital. They keep the whole structure from collapsing into chaos.
The floor and the walls.
Right. But the ethical principles, the respect, the autonomy, the beneficence, the relentless pursuit of justice, they are the light inside the building. They are what make the space actually worth inhabiting.
That is a phenomenal, truly beautiful way to synthesize this massive web we just explored.
It is a lot to take in.
It is. We have navigated an immense amount of territory today. Moving from the rigid, punitive rules of criminal law through the compensatory mechanisms of civil law, right into the strict geographic boundaries of nurse practice acts.
We covered it all.
We examined the 4 grueling elements of malpractice, the unforgiving privacy mandates of the Health Insurance Portability and Accountability Act, and the heavy emotional minefields of advanced directives.
And we followed that sprawling legal framework all the way up to the deeply human philosophical principles that guide the ultimate overarching goal of healthcare.
Which is fiercely protecting and respecting the inherent dignity of every single human being. It completely reframes everything you see the next time you walk into a clinical setting. It is not just biology happening in those rooms, it is philosophy, law, and humanity all operating in real time.
It really is.
As we wrap up this exploration, I want to leave you, the listener, with a final provocative thought. We spent today dissecting the rules and ethical frameworks we rely on right now.
Today's rules.
Right. But as medical technology continues to advance at an almost incomprehensible speed, allowing us to keep biological bodies alive far past the point of natural failure, integrating artificial intelligence into complex diagnostic decisions, and developing genetic treatments that alter the very fabric of human life, how will our fundamental definitions of doing good and doing no harm be forced to evolve?
That is the big question.
As science aggressively pushes past the historical boundaries of life and death, will our sluggish legal systems and ancient ethical philosophies ever truly be able to keep pace with the realities of tomorrow's medicine? It is something for you to deeply ponder.
It is absolutely the defining challenge for the next generation of healthcare professionals.
Thank you so much for tuning into this program at the Nursing Launchpad on the LPN Launchpad channel. We hope this exploration into the legal and ethical landscape has given you a powerful new perspective on the unseen rules of care. Keep exploring the boundaries of your profession, keep passionately advocating for your patients, and never stop asking the hard questions.